Moving right along in the world of elbow. By the end of this podcast, you should be able to differentiate between medial and lateral elbow tendinopathies and describe the treatment staircase for elbow tendinopathies. So meet Michelle. She's a 45-year-old female who works in housekeeping at your local hospital. She presents to you with a 3-month history of gradual onset right elbow pain. She's coming in now because it's starting to affect her work and she's worried about her job. This is the first time she's had trouble with her elbow and she's otherwise healthy. So what could be wrong here? Let's think about our options based on what's in the elbow. Could this be a fracture or dislocation, a muscle or tendon disorder, an arthropathy, a ligament problem, or is this the C-spine pretending to be an elbow problem? I've already tipped my hand in the objectives, but we're going to look at another tendinopathy, this time the epicondylitis. The red circles here show where the point of maximal tenderness is for medial and lateral problems. Unfortunately, these conditions have been saddled with common names of golfers and tennis elbow, which confuses more than it helps most of the time. Similar to rotator cuff tendinopathy, this is less about inflammation and more about disordered tendon structure and potentially vascularity problems. The difference in clinical presentation between the two directly refers to what the functions of the involved muscles and tendons are. For lateral, which is much more common, the provocative activities are gripping, because the wrist is typically extended for that, and resisted wrist or digit extension, and passive flexion stretch of the wrist. For the medial side, it's opposite. The ulnar nerve is right next door to the medial epicondyle, and it can either join the party or represent a competing diagnosis. This is usually a clinical diagnosis. In other words, history and physical exam are sufficient to make the diagnosis. But investigations, such as X-ray, ultrasound, and occasionally MRI, can be used to eliminate other diagnostic options in cases where things aren't clear-cut. When you examine Michelle, she's got good elbow motion, good strength of elbow flexion and extension. She has no motor or sensory changes in her arm and hand. She is tender just distal to the lateral epicondyle, and resisted extension of the wrist reproduces her pain. We've seen this staircase before. She's already doing the step 1 activities, but she needs a note to modify her work activities. Since these structures are close to the skin, topical anti-inflammatories can help. Unlike in shoulder, there are devices that can be worn to help. Many of you may have seen the straps that wrap around the upper forearm to help unload the painful area. Home exercises are important here, and we'll come back to this. The next 2 steps are controversial, and in the end, some are treated with surgical debridement. I've put supervised active rehab here with a question mark for a reason. The critical components of treatment here are time, relative rest, and a simple home exercise program with eccentric strengthening exercises. Once a patient has been taught them, the role of additional supervision or other modalities is somewhat debatable. Step 2 treatments will produce substantial recovery in 80% of patients by the end of a year. Surgery is not a miracle cure for this either, and there will be a small subset of patients in whom this becomes intractable. Corticosteroid use is more controversial here than in shoulder, but the philosophy is similar. As always, it should be paired with active rehabilitation. Because the area of injection is quite close to the skin, complications can include skin depigmentation and fat atrophy, which can not only produce an unsatisfactory cosmetic result, but it can complicate any future surgery. Platelet-rich plasma was hailed as a game changer for this, but with time and randomized controlled trials, it hasn't really held up to expectations. Like before, it's fairly benign, but it's also expensive. So Michelle is super motivated and gets started with treatment. She wears an elbow strap at work and a night splint for her wrist at night, and diligently does her exercises daily. Injections are postponed pending the results of the first round of treatment. She knows this will take a while to get better. Fortunately, after about 3 to 4 months of active treatment, things have eased enough for her to get back to regular work and activities. This is the most common elbow problem that a primary care physician will see in the office. The common principles of treating tendinopathies apply here.